Good evening, lovely people. On behalf of Beaker Street, I'd like to acknowledge that we're on the lands of the Tasmanian Aboriginal people, members of the oldest continuous culture in the world, who have passed along an unbroken chain of ancient knowledge of the animals, plants, waterways and skies of Lutruwita. We honour this wisdom and we are grateful to be able to come together on this land to discover and share knowledge. My name's Mark Horstman. I'll be your genial host and science nerd this evening. Well, of course, we're all science nerds here. That's why we're here, right? Are you ready to have your minds blown, Hobart? Yeah? All right. Let's get into it. Tonight, psychedelics, the future of therapy. That's a cliffhanger, but I should give you some housekeeping tips first. If you're after the toilets or accessible toilets, they're just outside the theatre doors. Right. Enough of housekeeping. The story is that in the 1950s and 60s, how many here can remember that? Researchers around the world were beginning to discover the clinical applications of psychedelic drugs. These promising new therapies were outlawed as part of the US government's and other governments' war on drugs, in inverted commas. Now, half a century later, the research programs have finally kicked back into gear, and Australia has become the first country to recognise two psychedelic drugs, MDMA and psilocybin, as medicines, legalising their prescription for certain conditions. Let me briefly introduce our speakers tonight. Dr. Paul Liknaitzky runs Australia's first clinical psychedelic lab within the Department of Psychiatry at Monash University, aka the Trip Doctor, and it's absolutely legal. He'll chat with Heather Rose, award-winning and much-loved author of 8 novels, like Bruni, and the new memoir, Nothing Bad Ever Happens Here. What might psychedelic-assisted therapy mean for all of us? Let's find out. Ladies and gentlemen, please welcome Paul and Heather.
Hello, Hobart. How are you? Good. You're looking very beautiful out there. I like the tables here. It's good, isn't it? Well, here we are on this very interesting, as part of this very interesting festival. I love Beaker Street. I'm excited by it. I'm thrilled to see it doing so well in Hobart and across Tasmania. So for those of you, if this is your first event, this is the kind of brain food that Beaker Street offers, so enjoy. It is my great pleasure, as Mark has said, to introduce Dr. Paul Liknaitzky. And Paul has a wealth of information that we're going to mine tonight. And I'd also like to acknowledge Ali and Priscilla for translating for us tonight. So Paul, tell us about the research you've been undertaking at Monash University.
Thanks, Heather. Lovely to see you all. Thanks for coming out. It's great to be here. Yes, I established the country's first psychedelic lab in 2020. I'd been a scholar of the field for perhaps a decade before that, and kind of apprenticing myself to the folk who were much further down the track than any of us here in Australia were. And so we develop and test a range of different psychedelic-assisted therapies for severe mental illness. And we also conduct training. We just completed earlier this year the world's first psilocybin-assisted therapist training. So it's a little bit different than therapy, where we gave our therapists high-dose psilocybin with support as part of their training, and assessed whether that was useful and whether it was safe and how to do it. So yeah, it's been a wild roller coaster ride in my world. None of us anticipated this field taking off like it has. In fact, I didn't even think, I thought I was making a kind of crazy decision trying to specialise in a field that didn't exist at all here. And when it started, it really felt like a little cottage industry, and that was only a couple of years ago.
So why were you drawn to it?
I think it's a little bit of a follow the white rabbit story for me. It goes back as far as I can remember. I wasn't taking psychedelics as far back as I can remember. But there really was something in my history that seemed to inexplicably be intrigued with certain kinds of altered state experiences. Perhaps the earliest memory I have that looks like this is myself as a 7 or 8 year old boy staring at a coffee table book. We had some Tibetan Buddhist friends, and they had this beautiful picture book, black and white photos of the ancient city of Lhasa with these Tibetan monks meditating with their big headdresses and eyes closed. And I just stare at those pictures like my friends stared at pictures of Superman. I was just intrigued. I didn't know why I was intrigued. I didn't know what was happening in there. And then started meditating as a teen. And then really, I did a PhD that was focused on a whole range of what we call induction methods, altered state induction methods. I was interested in common factors, whether there was something common, and particularly therapeutically common, across a whole range of what looked like very different kinds of ways of producing altered state experiences. Things like meditating, running for 24 hours without stopping, being in a lot of pain, rituals, consuming serotonergic agonists, all of these things. And while I was doing my PhD, the field of psychedelic psychiatry was really growing, and by the end of that, I knew that was where I needed to go. Yeah.
Fantastic. As you've mentioned, hallucinogens have had a very long history in human society, and almost every culture has had some form of hallucinogen that we've really used in sacred rituals for initiation and healing. But this is relatively new territory for the West. So tell us about modern research and how we came across our own form of hallucinogen in a laboratory.
Yeah. It's a very colourful, fascinating set of stories. Interestingly, that word hallucinogen has fallen out of favour now, in part because it's mostly a misnomer. The psychedelics that we use very rarely produce what you'd call a hallucination. So we refer to these substances typically these days as psychedelics, and that's a neologism that comes from the ancient Greek meaning mind manifesting. And really that's an ever-increasing umbrella term that now takes in compounds like MDMA and ketamine and iboga and all kinds of things. So the history as you say, the history goes very far back. I mean, we don't know how far back it goes. Of course, it starts to disappear into the mists of time. But there are some very compelling bits of evidence that date back at least 7,000 years of cave paintings with mushroom-adorned shaman in the caves of Algeria and the likes. And as you say, probably most or all civilizations around the world have deliberately used psychedelics to alter their consciousness for different purposes, not always healing necessarily. Seems that there's some historic and anthropological literature that suggests that psychedelics have been used for a range of different purposes, including augmenting perception during hunting and increasing kind of violent fervor before warfare and all kinds of things. It wasn't always pretty. And yes, the story goes that every nation around the world since prehistory used psychedelics, except the Inuit, it was always said, because nothing grows above the Arctic Circle. But as it turns out, Inuit drink reindeer urine that's laced with fly agaric mushrooms to get high. So everyone wants to get high. But but the contemporary story is an interesting one. There's definitely a strong through line that comes through indigenous practice. But in the West, the kind of earlier step than that was actually preceded that by about 10 years. Late 30s, Albert Hofmann, a Swiss chemist in Basel, invented LSD in an attempt to... He was working for a pharmaceutical company trying to develop a drug that could staunch hemorrhaging and could constrict smooth muscle. And he developed these lysergic acid diethylamide series, and he developed in many numbers. He numbered them as he went up, and he tested them on his rodent models, and he developed this one called LSD-25, and he tested it on his rodent model, and it didn't do what he wanted, and he put it aside. And then inexplicably, he describes in his memoir, he was fascinated with the chemical structure of LSD-25. And a full, what would have been 4 years later, 43, he resynthesized it tested it again, accidentally got some in his body somehow. It's a very potent psychedelic, and one of the more potent ones, and you only need a very small amount in the microgram to get a high. He accidentally ingested probably finger on his eye, and had a bit of a lightweight trip. And that was on a Friday afternoon, and then, it's 1943, and in those days, every good chemist, would do what he did, which is come back on Monday morning and try it deliberately. And so he did that, and he had the first deliberate psychedelic trip, and he thought the typical thing you do if you're going to be self-testing is you start with a dose that you think is definitely not going to do anything, and you titrate up from there. And so he picked 200 micrograms, thinking that would be about a tenth of what he needed. 200 micrograms is a whopping trip. And that day's activities, which most famously involved a very intoxicated bicycle trip through Basel, is commemorated every year on Bicycle Day, where everybody takes LSD and rides bicycles around. So that's, Albert Hofmann really is the kind of the early story there, and Hoffman continued on to work in psychedelic development as a chemist and passed on these compounds mostly through the late 40s and early 50s to a number of psychiatrists and psychotherapists who started using them in practice. About 10 years later, in 53, there's another story which has the indigenous through line where R. Gordon Wasson, a kind of ethnomycologist, an amateur mycologist, traveled to Mexico and met the Mexican curandera, Maria Sabina, who invited him into secret ceremony, and he brought that to the West, and through Aldous Huxley's writing made that very, very famous.
Yes, and you, in your work at the moment, you're using MDMA and psilocybin, so I thought it would be helpful if you could tell us what is MDMA and also why you use a synthesized version of psilocybin when it occurs naturally, obviously.
Yeah, good questions. Yeah, and also, just as of last month, we've started using 5-MeO-DMT in our trials as well.
Right.
All contemporary trials that use psilocybin, which is now the flagship psychedelic, the first wave of psychedelic psychiatry through 50s and the first half of the 60s mainly, used LSD primarily. We used psilocybin since about 1999 when things took off again. Most people who do this work use psilocybin, in part because it fits into an 8-hour day. LSD's got a longer kind of tail there at the end of the day, and gets a little tiresome at the 10th and 12th hour. But also, there are a number of advantages of psilocybin. One of the reasons is it's not spelled LSD and didn't come with the stigma. But and we use pure psilocybin largely because that is kind of standard within pharmaceutical practice to get. We have to use medical grade psilocybin. It has to be very pure.
Right.
And it's actually easier to do that chemically than it is to do it through organic matter. But there probably will be organic type options in future, for sure. And then MDMA, it is a synthetic compound. It doesn't grow on trees. Yeah.
And it's drawn from similar things as LSD, MDMA?
No. It's actually even in a different chemical class. So psilocybin is what they call a serotonergic tryptamine. It's a type of DMT, a type of dimethyltryptamine. DMT is a very famous psychedelic, often used in very short-acting ways, usually smoked, and it has an onset of about 10 seconds and usually a high of about 30 minutes or so. Psilocybin is different when consumed. It's got its onset of about 30 to 90 minutes and a trip duration of about 6 hours or so. And almost all of its effects, probably all of its effects that we are able to perceive, are produced via what's called the serotonin 2A receptor, which is basically what happens in your brain is these chemicals go in and they're a little bit like a key, and in your brain you've got all these locks, and the key goes into certain locks and unlocks it, and all kinds of great magic happens inside your brain. And so it seems like psilocybin and LSD are working at one receptor subtype, one particular lock, and producing this vast array of bizarre effects. MDMA is what's called phenethylamine, which is a bit of a different class of compounds, and it actually stimulates the release of serotonin into your synapse. So rather than being just like a lock in a key in a lock, it causes a flooding of serotonin in the synapse and works quite differently. And the effects of MDMA are quite different. It's actually, until quite recently, people wouldn't have thought of it as a psychedelic.
Yes, it's interesting it's come into that world, isn't it?
Yeah.
But they do more than affect our brains, don't they, psychedelics? Because sometimes they appear to alter our worldview, our fear of death, our sense of interconnectedness, and to evoke spiritual and even divine experiences. Why does that seem to happen?
Wow, yeah, big question. It's mysterious in many respects. Why do we have a serotonin 2A receptor just sitting around in the brain waiting for a psychedelic to come along? Mysterious as to why these drugs produce such a widespread array of effects. But we do know a lot of what happens once those receptors are docked in the brain. We know a lot about what happens in the brain and the changes that flow on from that, and the kind of experiential elements of that, the kind of subjective correlates of it. And as you say, these are phenomenal experiences for a lot of people. I mean, MDMA and the classic psychedelics like LSD and psilocybin, they have quite different kinds of experiences. MDMA is often referred to as an empathogen, which increases a sense of empathy and closeness and connectedness. And the key thing, if you want to, in a bit of an oversimplistic way, if you want to understand a bit of what MDMA is doing, it's increasing your tolerance for distress, so things don't bother you, typically. And that's phenomenal in and of itself, because one of the things you notice and these are the reports that we're often hearing from people that are taking MDMA who do not have a psychiatric condition, is that they are noticing that they have been anxious all the time. Like the base rate of the human condition is a kind of anxiety. And when you have relief from that anxiety, an amazing kind of array of experiences are available to you, like this ability to connect to other people without being so worried about your status or what they think of you, or your being affirmed in some way. And you get to perceive more than you normally perceive. I mean, I typically think that this is one of the actions that even the classic psychedelics are allowing for us to experience, which is, Huxley referred to this as this reducing valve. We know that the brain is fundamentally constraining our perception and inhibiting activity so that we see and observe the world through the lens of our own survival. And maybe for those of us who are fortunate enough, it's not about the survival of your body, it's the survival of your status or whatever else you care about. But it's a very tight constraint, like an aperture on a camera lens that's really pulled in tight. And MDMA, differently than something like psilocybin, but the mechanisms are a bit different, but both serve to, if you like, enlarge that aperture on the world, that aperture that's constrained fundamentally by anxiety and avoidance. And you get more information. You genuinely get more information. Whether that information is useful or valuable or good is worth arguing about. But you definitely get more perspectives on yourself and the world and old problems. And you get to take things in a way you typically cannot take in usually. And a lot of people will describe this feeling of like seeing the world through fresh eyes, like as though they've never looked at the thing they're looking at or taken it in ever. Their husband or the tree outside their office or whatever, go, oh my God, I've never actually looked at that. And it's a phenomenal experience. So that's MDMA is kind of doing this reduction in distress while keeping you engaged. So it's a little bit, it's not like heroin, which can also reduce your feeling of distress, but heroin kind of takes you out of the world. It knocks you out. You're not deeply curious about like who's in front of you or trying to like solve a problem or engage. Whereas MDMA keeps you very engaged, which is good for psychotherapy. And so one of the key use cases for MDMA these days is in dealing with PTSD, trauma. And that's in part a form of exposure. So one of the best things you can do for trauma, if you can do it well, is you go back to the traumatic memory or the stimuli, and you find a way to form a new relationship to that, so that when the chopper sounds in the distance, or when you see a man's face or whatever it is that triggers you, you don't go into that fight-flight response. And with, typically with exposure therapy, it either, is not something people want to do. Most people with severe PTSD, when they sit down in front of a psychologist who says, let's talk about your problems, that's the last thing they'd want to do. And sometimes it can even re-traumatize people.
Yes.
So with MDMA, you get to go very close in on these traumatic memories and experiences and find a new way of relating to them. And that new way is not very cognitive, it's very embodied and affective.
Yes.
And we had these, fascinating reports from, we're watching these videos when we did our MDMA training, and this one report really stuck with me of this man who was serving in Afghanistan, and he'd been to therapy for, I think it was over a decade for this traumatic experience where the tank he was in was hit by a grenade, and he hadn't actually, through that whole therapy, been able to really go back to that time. But while he's there on MDMA, he's recounting being in the tank, and it's like super slow-mo, high definition, all these amazingly preserved memories, the color of the shoelaces of the guy in the tank underneath him as the tank's hit, able to just observe everything so serenely, and then, able to observe things from a very different kind of perspective, like having compassion for the perpetrators, for the enemy. Yeah.
Hence the empathogen.
Yeah, exactly.
Right.
Yeah.
That's beautiful, isn't it? That's an incredible gift that is being made available.
Yeah.
So if we go back to psychedelics, the traditional psychedelics, in the 1940s and 1950s, psychiatrists were having extraordinary results, partly with people who had addictions.
Yeah.
So tell us about that, because it's really an important bit of our history that was then put on hold.
Yeah, that's right. Yeah, so LSD was possibly or probably administered to about 40,000 people, and mostly that was for people with what was then referred to as alcoholism, alcohol use disorder.
Yes, right. Alcoholism.
Yes. And the effects were varied, and in those days, they didn't quite have the same standards of care and practice and science, so it's a mixed bag. But they were getting incredibly impressive outcomes for sure. And they were using LSD also for a range of other issues beyond the addictions. There was opioid use disorder that was also being treated then, and people with various malaise, in those days often was referred to as neuroticism. And yeah, the thing here is that we carve out, psychiatric disorders in very small bits. We have a manual called the Diagnostic Statistic Manual, and we get more than 300 ways in which you can suffer. But we know that if you drill a little deeper beneath the surface there's a lot in common between somebody who uses alcohol to dull their pain and somebody who ruminates depressively to dull their pain, or somebody who becomes obsessive and compulsive about something to avoid their pain. Fundamentally, like one of these kind of key pieces, and it's certainly a lesson that we see emerging in the psychedelic sessions, but certainly something that's been known for a long time through mental health research, is that avoidance is like a fundamental driver of pathology.
Right.
Yeah. And so there's, really...
Tell us more about that.
Yeah, so I guess there's a way in which, the universe wants to be included. Like everything in the universe, for things to be healthy, it seems, we need to be honest about reality and need to include things. And pathology arises when we attempt to, avoid or fabricate the world around us. And it's completely understandable and normal and natural that there are a lot of things that we all want to avoid. That makes a lot of sense. But that can become dysfunctional, can become severe, can become extreme. And so one of the things under psychedelics are these amazing tools, not only for treating people with mental illness, they're also just an amazing tool to understand the human condition.
Yes.
You get to see, it's like ramped up and exaggerated. You get to see, a whole lot of things play out a little bit like a dreamscape that play out in our lives, but in a more dilute and diffuse way that you often can't perceive. So, one of the key approaches within psychedelic therapy, and one of the things that's a bit different than psychiatry, psychiatry and I don't want to malign psychiatry. There's wonderful results in psychiatry, and it's got a use case that makes a lot of sense. But fundamentally, without psychotherapeutic approaches, psychiatry is attempting to minimize or mitigate aversive symptoms, things that you don't want to feel. You put a cap on that, and that can save people's lives. With psychedelics, we're attempting to do almost the opposite in the short term. We're attempting to go as close and as deep into the sources of our distress and find a new way of relating to that. There's a nice Joseph Campbell quote that characterizes our approach quite well, which is, the cave you fear to enter holds the treasure you seek. And we see this a lot in our therapies, that these nightmarish monsters, whether they are visionary within the acute psychedelic trip or whether they're just a part of your history and your personality and your life, these are your allies in disguise. Like, we see that a lot. But like in a dreamscape, the faster you run, the bigger the monster gets. It chases you. Your legs start to become wobbly. You can't get away, And so a big piece of the preparatory phase before we give psychedelics, and it's worth noting, we only give these high-dose psychedelics with a lot of therapeutic support. A big piece of that is finding a way to increase a person's capacity for trust, their capacity to let go, and their capacity to be inclusive, as in, let happen what's happening.
Yes.
Whatever is in the way is the way. And that's our approach. And so that lesson for how it works with psychedelics, and that's like, there are different schools of psychedelic psychotherapy, but some of these things are just like dictated by psychedelic experience. Like, if you don't deal with that, you're going to have bad trips.
Right.
And that gives us an amazing kind of, microcosm of the human condition, because that's what happens too. If you avoid, at some point, you're going to find yourself in a dysfunctional state. Yeah.
So if we go back to the 40s and the 50s with those results, would you like to talk a little bit, just to give us a sense, the longitudinal effects were, I think, what struck me more than anything. It wasn't that these people just suddenly stopped needing to drink alcohol. This went on, and a huge proportion of them went on never continuing any form of alcoholism.
Right. Yeah, interesting. Yeah, so...
It's unusual,
It's
isn't
unusual,
it?
yeah. It's unusual. I mean, it's worth saying, again, that we have different kinds of practices, and through history there's a diversity of practices, and the outcomes are diverse as well.
Sure.
So it's not a cure-all, it doesn't work for everybody, and for many people, it's the most common story is not one and done. Sometimes it's the case. I've definitely met quite a few people, and we have a few people that have come through our trials where that's it, like, and who knows, but we're a year later for some of them, and they're swinging from the chandelier still, and you wouldn't have recognized them when they walked through the door the first time. It's phenomenal. I honestly still feel, like, every time that happens, I feel surprised. Even though I work in the space and I know there's reason to work in the space, I'm by no means an evangelist, and I can see the promise here, but when it actually works like that, and it often works amazingly, I'm surprised. It's incredible.
Miraculous.
It can feel like that, and for those people too, yeah. But often the story is one in which you get like a leg up, and then you've got work to do, and that work continues for the rest of your life. Now, for a lot of people with alcohol use disorder, they can't, this is the most common story is trauma masked, and so, and trauma is arguably among the more curable of the mental health disorders, because it depends what kind of trauma, and it really depends a lot, but particularly when you have these kind of index traumas, there is a way to go into that traumagenic stimuli, and reappraise in such a profound way that it never hurts you again. But yeah, this is the thing, that I guess if you're involved in some sort of pathological behavior, whether it's thinking or something else that you're doing, like drinking alcohol excessively, and it's trauma-based, and you have these kinds of experiences that can really kind of get to the root and turn things, then yeah, you can get these long-term outcomes. And we do see in a lot of trials, people, so far the data's mostly gone out to like 1, 2, and in a few trials 3, 4 years beyond, in the contemporary era, beyond the treatment. And we are seeing in some trials relapse, like some trials that are, and I've got my pet theories for why some people are seeing more relapse than others, and other trials where you're seeing amazing persistence in benefit at 3 and 4 years post-treatment. But that is the hard nut to crack, and that is the real test for psychedelics. Do we get high rates of remission of psychiatric disorder in the long term? Does it endure?
Great.
Yeah.
And so when we go back again to the 60s and the challenges that then arose, I mean, it's a very interesting time. We've got the civil rights movement, we've got the pill gives women all this sexual freedom, America's at war in Vietnam, moon landing. The CIA is testing LSD on people as a potential weapon of mind control, and Timothy Leary and Richard Alpert at Harvard are doing experiments using psychedelics and LSD, psychedelic mushrooms and LSD to Harvard students, and neither substance was illegal at the time, but then the US government, towards the end of the 60s, classifies LSD and psilocybin as a banned substance with no medicinal value and as highly addictive. That was untrue. They had proven medicinal value and were non-addictive, but looking back, can you think of another example of such prohibition in science?
No, this is without parallel, for sure. Yeah, the story around the demise of psychedelics in medicine through the early 70s is a little more complex than Nixon's war on drugs, but it's mostly that. Part of it was also that the regulator in the US, the Food and Drug Administration, introduced what's called the randomized controlled trial as its gold standard to assess whether something works or doesn't. And psychedelics are famously bad for blinding, what we call blinding. That is, there's no points for guessing who's had the real thing. Yeah?
Aspirin, LSD.
Yes, that's right. That's right. There's a great little meme going around now where there's like a group of people sitting in a waiting room looking bored, and there's another group of people like dancing naked, and it's like they say, it looks like we're in the placebo group, So that's part of it, and there were a few other factors there, but yeah, absolutely, it was clear to Nixon and John Ehrlichman and the folk in that Schonke administration that LSD was something to be feared, and they were right. My contention is they were right, that LSD did play a part in the countercultural movement and in the anti-war sentiment, and they were very concerned about this hippie uprising, and the war was very unpopular already in 1970, and so they classified these as what are called their Schedule 1 drugs, the equivalent here is a Schedule 9 drug. And there was this, international treaties through the UN Convention, and almost every country on earth signed up for this lie, phenomenal lie. Yeah.
Yes, and then we wait to the end of the 90s, and permission is given to start trialling psychedelics again. So here you are in 2023. Your program is running for
about 2.5 years.
2.5 years. So what sort of people come forward to volunteer for your research program?
Oh, well,
what are
every kind of person, because people are wanting to get it. Yeah. Even people who just like a trip. Yeah. We have an unbelievable, amount of people that apply to get into the trials. And to be fair, a large portion of those have mental illness and are struggling and looking for solutions that they haven't been able to find. In a research trial, we're limited in a number of ways that future clinics won't be limited, which is a good thing. And one of the reasons among many that I'm involved in opening up a new clinic at the end of this year under this new scheme that Australia's brought in. But we have kind of safety concerns, and then we've got scientific questions, and that limits the kind of candidate that enters the trial. We've got our longer running trial is for generalized anxiety disorder. And that's one of the most prevalent anxiety conditions. About 4% of Australians are diagnosed with generalized anxiety disorder, and far more have subdiagnostic symptoms. But these are folk who are also, many of them courageously living their lives despite what feels like a crippling issue that tracks them. Yeah, I mean, I think of so many, I think of one of the people that is swinging from the chandeliers nearly a year later, just a beautiful, brave soul who, lived through her mothering and career as a teacher, despite this, just carried on as best she could, but really felt like she was disabled for decades, barely able to do anything without feeling crippled by anxiety. Yeah, so it's people like you and I, but who have maybe, not had as much resourcing or support, or maybe had a tougher, set of cards dealt them at the beginning.
Yes, absolutely. And so how many people have now gone through your trials?
These trials are, they're hefty beasts to get up and run, so they've got a long lifespan. So in our lab, there are about 60 or so that have come through so far. And we have, a lot of them have a long kind of lead-in time, to get to the start line takes a while. So we're about to start a few trials that will be active over the next couple of years. And as I said before, we also gave the opportunity to our therapists or therapists on one of the trials to have psilocybin with support as part of their training. So there were 14 of those brave souls as well that did that.
Great.
Interesting one, because it's one of these things that can feel like it's on the sidelines, and the main game is making a difference in this mental health context with epidemic proportions. And it really is. It's really a situation that we've got on our hands these days. About 2 in 5 of us over the course of our lifetimes will get a psychiatric diagnosis.
Yes.
A little more than 2 in 5 of us. That's nearly half.
What's your sense of the statistics on that 50 years ago?
It's hard to know, because there was a lot of mental health stigma, so people are now coming out about their mental ill health. And there's a lot more measuring now, and there's a lot more, prescribing. It's really hard to know, but it looks like certain kinds of issues are getting worse, and in some subsets of our community getting worse.
And where do you notice the subsets?
Well, it's shocking. I mean, and this is kind of very personal for me. I've got an 11-year-old daughter, and it's scary because I look at the stats on 15 to 20-year-old girls. Half of them get a psychiatric diagnosis in this country, and that means a good portion of those who don't get a psychiatric diagnosis have subdiagnostic symptoms or aren't diagnosed, but they're struggling.
It's extremely concerning.
Yeah, it is. And so there's a confluence of things. I mean, we can get into it, but it's complex, and everyone's got their ideas for why, what drives mental ill health. I mean, certainly one of the most consistent things that we've seen over the last 50, 60 years in the research, and something that's very kind of close to my heart and mind when I think about what we're doing, is that adverse childhood experiences seem to be playing a huge part in psychopathology. That there's a trauma base.
Yeah, there's a trauma base, yes. Although we've come to understand a great deal more about trauma and its effect on all sorts of mental ill health, haven't we?
Yeah.
That's a whole field of specialty,
absolutely.
isn't it? So when you think back to your 60, and I know your trial is ongoing and you haven't got any conclusive data yet, but what are some of your participants reporting? You've shared the story of the woman with anxiety. Any other stories that you...
I mean, there's so many. Everybody's got, a very, it's interesting. There are these kind of, what feel like really common humanity elements that sit in the subterranean space a little under the symptoms. But then very nuanced, idiosyncratic ways in which they're expressed. And that's, the kind of, the art of a good psychotherapist is that capacity to provide that support that is tailored to you, like attuned to you and your particular way in which you've dealt with or coped with the struggles in your life. But then track you to these kind of fundamental sources of distress and the ways in which we know we can repair. So we've seen everything from, we've had people, laughing for like, I don't know, it would have been, I remember coming back in the hall and just hearing this again and again, maybe 4 or 5 hours of like hysterical laughter, you know, people like congregating outside the kitchen going like, what is going on in there? We've had similar durations of like sobbing. And we've had, you know, people, everything in between and oscillating from one to the next. There's, you know, we've had a lot of people reporting that to be among the most important experiences of their lives, if not the most.
Yes, and this is up against death of a parent or birth of a child. Yeah. It's extraordinary, that, isn't
there
it?
are some people that's our Tuesday afternoon, and that for them is the pivotal moment of their lives.
And they report this again several years later, that it still holds up as this extraordinarily significant event.
Absolutely.
And why do you think it's that? Is it the insight that they gain? Is it the whatever the drug releases in them?
Yeah, interesting. Yeah, I mean, again, a lot of diversity in what people report. So people will often have this kind of visionary experience that is almost like a tour of their psyches and their history. But it's from very unfamiliar perspectives. And some of that can be deeply challenging, some of it's blissful, you know, people can experience all kinds of different things when they go deep into their biographies. And some people don't even go into their lives. Some people just have this, what people might describe as a transpersonal type experience, where you know, where they're relieved of suffering in some profound way, and they recognize, you know, it's a little bit like people often describe something that's like the overview effect that astronauts get, you know, when you can kind of put the whole world and everyone you've ever known, all of history behind your thumb. It puts things into perspective. And I think this is a common report that people will say, you know, I got this new sense of hope, or I got this very vast perspective on life, and my worries are now small, or they can't beat me in the end, or there's something far bigger here. There's also this interesting thing that and it kind of makes sense if you think about it, but you know, a lot of the people that come to our trials have been trying in some way, chipping away at you know, a good life and struggling. And then they have these psychedelic experiences that bring them you know, these very new perspectives. Now, it's important to say that insight's a bit of a misnomer, because when we think of insight, we think of like a thought, like a great new thought. Psychedelic insight is typically not that. I think that's what you get afterwards. It's like an artifact that's left over. But what it is this non-linguistic, non-cognitive kind of revelation, or you know, it's often embodied or affective in some way. And a common report is that it is one of being surprised. Like people are surprised by what they learned, or surprised by what they kind of go, well, I didn't realize that that's what my issue was, or I didn't realize that I needed to go in that direction. And it makes sense, you know. It's like the Einstein quote: "You can't fix a problem with the same system that built it." Yeah. So there's often this kind of surprise, and it comes with a rich feeling of you know, meaning, and like you say, many years later, it retains its authority, which is phenomenal. And part of, you know, what may have is a potential underbelly or a potential dark side to all changes, I believe, and that little bit there is critical. That you don't wake up the next day and go, that was just a drug-induced delusion of some sort. You don't discount it. It's not like, you know, when you write a poem on you know, when you smoke a joint and write a great poem, and the next morning you realize it wasn't that great a poem. You know, this is different. You know, people feel like they're waking up out of the dream of their lives, like they've never been this sober. It's very sober and lucid, and lots of new information, and you're clear. And one of the keys, you know, one of the things we're doing in our lab is attempting to find ways to retain proximity. This is what I refer to as psychedelic proximity. So that 6 months or a year later, you're not just left with these cognitive linguistic artifacts, these thoughts.
Yes.
You know, like mum also had her struggles. But that you can still feel that mum also had her struggles.
Yeah,
and that takes a bit of work. Preceding the dosing session, during it, and after, there are things that you can do that can help link people in. And their practices. I often think about psychedelics as like a compass, like set a compass, And then you need a vehicle, because a compass is of no use if you're going nowhere.
So how, as a practitioner, do you help the vehicle? How do you do that? And we, unfortunately, we only have another 10 minutes or so.
Yes.
So I want to also ask you if you can touch on the therapists also experiencing these psychedelic experiences so that they can work with the patient in a way that informs the choice the patient makes and the experience the patient has and the support that the patient feels they will receive, the empathy that they then share for the experience, and the risks and challenges of this new world where this medication can be prescribed.
Those are lots of questions.
Sorry,
Heather.
Paul, but I really want us to get across those.
You've been giving me little questions and I'm giving you big answers. Now what am I going to do?
Where are we going with it? Where are we going with this?
Well, I mean, we're in a brave new world here. I mean, no one thought that Australia would
Be the first.
leapfrog to the front of the pack here, yeah?
So explain to the audience what's actually happened and what can be prescribed now.
So as of July 1 in Australia, two substances, psilocybin, which is the active ingredient in magic mushrooms, and MDMA, which is found in ecstasy, have a different way of being scheduled. They now get to be classified as controlled medicines if they're used by special authorized psychiatrists in the treatment of certain mental health indications. So psilocybin for treatment-resistant depression and MDMA for PTSD. There are a few other countries in the world where these drugs are used outside of clinical trials, but very few and very restricted. And these are like expanded access or early access type programs, and it's very hemmed in. This is the first time where we don't know how scaled up it'll be, because there are a whole lot of guardrails and constraints. But it's the first time that psychiatrists can get authorized to prescribe these drugs with therapy, with psychotherapy as part of treatment. And as I said before, I'm going to be involved in setting up, or I am involved in setting up a clinic that'll open its doors hopefully end of this year. It's an interesting kind of interface for me to work at, but one of the things that is clear to me at this point in time is we've learned a lot in a short space of time in our lab. I mean, it's one thing to learn from the folk overseas who've been at it for longer than us, and that's been invaluable, but you really get a whole different education when you're at the coalface yourself. And we've learned what we think of as methods to improve outcomes. And my chief reason for wanting to be involved in a clinic like this is that we get the opportunity to build a client-centric treatment model that is not constrained in the same ways that our research trials are constrained. So we'll have tailored and extended care. Our standard care will span 9 months, standard treatment block. And that's because we recognize that you need a vehicle.
Yes, but that's still a lot shorter than 25 years with a psychiatrist or a psychologist, isn't it?
Right, that's right. And if it works, if we actually fulfill the promise, then we'll be seeing higher rates of remission in the longer term. But you've got to screen in people who are well suited, and you've got to deliver really good care. And we've got just fantastic people that we've worked with and who've now got runs on the board, and just feels like a wonderful opportunity to do this work now. So that's what's starting in Australia soon. And I imagine there'll be an array of different qualities and different approaches and all that. So it's not to say it's all necessarily going to be a good thing. But hopefully people do a good job and are diligent in the way they do it. To your question about the therapist, I think this is an interesting one. I might be kind of asking a little bit too much. I mean, maybe I should just be grateful that I have a job in psychedelic therapies and not push the envelope even a bit further. But I really do feel like this is not just about envelope pushing. That my sense is that perhaps the most potent lever we can pull now in rolling out psychedelic therapies in a mainstream mental health care context is in training up the professional community that holds that space. And it is no trivial matter to hold that space. You might be a wonderful therapist and quite proficient at being equal to your client in an ordinary state, and then they drop into the subterranean psychedelic space and everything's different, and you may not be equal. And one of the things that we've found is that there are limits, just like with talk therapy and other forms of therapy, there are limits to training. There's only so much somebody can tell you before you need to have a lived experience to understand what it is they mean, and particularly when they're dealing with the ineffable and the inconceivable, which is what we have with psychedelics. So we gave our therapists that opportunity. It shouldn't be mandated, and it's not. Some people shouldn't, even therapists shouldn't do this. And 14 of them underwent this process, which was an incredible opportunity also for the team to bond at the very beginning of the projects. And we assessed the outcomes through that, and we're still assessing long-term outcomes in terms of their rated competencies and their experiences and their feedback on the whole process. You know, the kind of punchline on that one was incredibly useful, even for, these are experienced, qualified mental health care workers, psychologists, psychotherapists, psychiatrists, who already had a training with us that spanned 3 months and then underwent this process, and many of them said that was the most useful bit.
Yes.
Yeah, and my sense is that it's an important line of inquiry to progress, and if it turns out to be as good as it looks, it may be one of the most important things that somebody like I could do in this space for the betterment of clinical patients in the future.
Well, thank you so much for the work that you've done and that you're doing, and thank you for coming to talk to us about it and sharing it with us tonight. Dr. Paul Liknaitzky.